Healthcare System Lecture: Hospital Care, Long-Term Care, and Pharmaceutical Services. Introduction to Healthcare Delivery Systems. The modern healthcare delivery system represents a complex network of institutions, professionals, and services designed to meet the diverse health needs of populations. At the heart of this system lie hospitals and long-term care facilities, which serve as critical access points for acute and chronic care services. Understanding the evolution, structure, and financial mechanisms of these institutions is crucial for healthcare professionals, particularly pharmacists, who play an increasingly vital role in patient care outcomes. The transformation of healthcare delivery has been profoundly influenced by the introduction and expansion of health insurance coverage throughout the 20th and 21st centuries. This evolution has reshaped not only how healthcare services are accessed and delivered, but also how institutions are organized, financed, and incentivized to provide care. The interplay between insurance coverage, payment mechanisms, and quality outcomes continues to drive innovation and reform in healthcare delivery models. Historical context: healthcare before and after insurance. Before the widespread adoption of health insurance in the 19th century, healthcare access was primarily determined by individuals' ability to pay out of pocket for services. This system created significant barriers to care, with many individuals foregoing necessary medical treatment due to financial constraints. Hospitals frequently operated at financial deficits, with many institutions struggling to maintain operations or declaring bankruptcy due to unpaid patient bills and charity care obligations. The landscape began to change dramatically with the introduction of employer-sponsored health insurance plans in the early 20th century, accelerated by World War II-era wage controls that led employers to offer health benefits as compensation alternatives. This shift fundamentally altered the demand for hospital services by removing financial barriers that previously prevented many individuals from seeking care. The post-insurance era of healthcare delivery has been characterized by increased utilization of hospital services, enabling institutions to invest in advanced technologies and expanded service offerings. Health insurance created predictable revenue streams that facilitated long-term planning and capital investments, leading to the sophisticated hospital systems we see today. This transformation also enabled the development of specialized services and the recruitment of highly trained healthcare professionals. The introduction of Medicare in 1965 represented a watershed moment in healthcare financing, providing universal health insurance coverage for Americans aged 65 and older. This program not only expanded access to care for elderly populations, but also established the federal government as a major purchaser of healthcare services, giving it significant leverage to influence provider behavior through payment policies. Medicare's Inpatient Prospective Payment System, IPPS, implemented in 1983, revolutionized hospital reimbursement by shifting from retrospective cost-based payments to prospective diagnosis-based payments. Under this system, hospitals receive predetermined payments based on Medicare Severity-Adjusted Diagnosis-Related Groups, MSDRGs, creating strong incentives for efficient resource utilization and cost management. The IPPS fundamentally changed hospital behavior by aligning financial incentives with efficiency objectives. Rather than being reimbursed for all costs incurred, hospitals now had a clear financial motivation to provide care efficiently within the constraints of the predetermined payment amount. This shift encouraged the adoption of clinical protocols, length of stay management strategies, and quality improvement initiatives that could reduce costs while maintaining or improving patient outcomes. The MSDRG system classifies patients into clinically coherent groups with similar resource consumption patterns, enabling more accurate payment adjustments based on patient complexity and severity of illness. This classification system has undergone continuous refinement to better reflect advances in medical practice and technology, ensuring that payments remain aligned with the actual costs of providing care across different patient populations. Building upon the foundation of prospective payment, the Affordable Care Act of 2010 introduced the Hospital Value-Based Purchasing (VBP) program, which ties a portion of Medicare payments to hospital performance on quality metrics. This program represents a significant evolution from volume-based payment toward value-based care, emphasizing outcomes and patient experience alongside efficiency. The VBP program evaluates hospitals across 4 key domains: mortality and complications, healthcare-associated infections, patient safety, and patient experience. Hospitals that demonstrate superior performance or significant improvement in these areas receive incentive payments, while those with poor performance face payment reductions. This approach has encouraged hospitals to invest in quality improvement infrastructure and systematic approaches to reducing preventable complications. The impact of value-based purchasing extends beyond financial incentives to fundamentally reshape hospital culture and operations. Healthcare institutions have increasingly adopted evidence-based practices, invested in clinical decision support systems, and implemented comprehensive quality monitoring programs. These changes have contributed to measurable improvements in patient safety indicators and clinical outcomes across the industry. The complex and competitive healthcare environment has driven hospitals to pursue various integration strategies to achieve economies of scale, expand market presence, and enhance care coordination. Horizontal integration involves affiliations or mergers between hospitals, allowing institutions to share resources, reduce administrative costs, and offer specialized services that might not be viable for individual facilities. Horizontal integration enables smaller community hospitals to access sophisticated technologies and specialized expertise through partnerships with larger health systems. These arrangements can provide rural and community hospitals with access to advanced imaging equipment, specialized surgical capabilities, and subspecialty consultation services that would otherwise be financially prohibitive for independent institutions. Vertical integration represents a different strategic approach, involving the creation of integrated delivery networks that provide a continuum of services across different levels of care. These networks typically encompass acute care hospitals, outpatient services, rehabilitation facilities, home health agencies, and nursing homes, allowing for coordinated care management and potentially improved patient outcomes. The advantages of vertical integration include enhanced care coordination, reduced duplication of services, and improved ability to manage population health. By controlling multiple points along the care continuum, integrated health systems can better coordinate transitions between care settings, implement standardized protocols across facilities, and align incentives to optimize overall patient outcomes rather than optimizing performance at individual facilities. Hospitals are typically classified based on several key characteristics that reflect their mission, patient populations, and service offerings. Length of stay represents one primary classification criterion, with acute care hospitals providing short-term services, typically less than 30 days, and long-term acute care hospitals serving patients requiring extended treatment periods, 30 days or more. The distinction between acute and long-term care reflects fundamental differences in patient acuity, resource requirements, and care objectives. Acute care hospitals focus on treating immediate health crises and stabilizing patients for discharge to lower levels of care, while long-term acute care hospitals serve patients with complex medical conditions requiring extended monitoring and treatment, such as those recovering from major surgeries or managing chronic conditions with acute exacerbations. Service type classification distinguishes between general hospitals, which provide a broad range of medical and surgical services, and specialty hospitals, which concentrate on specific disease processes or patient populations. General hospitals serve as community healthcare anchors, providing emergency services, general surgery, internal medicine, and obstetrics, while specialty hospitals focus on areas such as cardiac care, orthopedics, psychiatric services, or pediatric care. Hospital ownership structure significantly influences institutional priorities, governance, and community relationships. Public hospitals operated by federal, state, or local governments often serve as safety net providers for uninsured and underinsured populations. Nonprofit hospitals, which represent the largest segment of the hospital industry, are governed by community boards and must demonstrate community benefit to maintain tax-exempt status. For-profit hospitals owned by investors or corporations operate with explicit profit motives while still being required to provide emergency care regardless of patients' ability to pay. Hospital pharmacy departments represent complex organizations that must balance distributive functions with clinical services while ensuring medication safety and regulatory compliance. The traditional model, led by a director or assistant director of pharmacy, encompasses multiple specialized roles, including staff pharmacists, clinical pharmacists, pharmacy technicians, and support personnel, each contributing essential expertise to medication management. Pharmacy directors bear comprehensive responsibility for departmental operations, including personnel management, budget oversight, policy development, and regulatory compliance. These leaders must navigate complex relationships with medical staff, nursing departments, administration, and external regulatory bodies, while ensuring that pharmacy services support broader institutional quality and safety objectives. The role requires both clinical expertise and business acumen to effectively manage resources and optimize patient outcomes. Staff pharmacists primarily focus on distributive functions, including order verification, medication preparation, and inventory management. These professionals ensure that medications are accurately dispensed, properly labeled, and safely delivered to patient care areas. Their work requires meticulous attention to detail and comprehensive knowledge of drug interactions, dosing protocols, and preparation techniques, particularly for complex sterile preparations. Clinical pharmacists have emerged as essential members of interdisciplinary healthcare teams, providing direct patient care services including medication history taking, therapy optimization, adverse event monitoring, and patient education. These professionals participate in patient rounds, make therapeutic recommendations, and serve as medication experts for other healthcare providers. The expansion of clinical pharmacy services has been associated with improved patient outcomes and reduced medication-related adverse events. Pauly et al., 2006. Pharmacy technicians play crucial support roles in medication distribution and preparation, working under pharmacist supervision to perform tasks such as medication compounding, inventory management, and prescription processing. The scope of technician practice continues to evolve, with many states expanding technician responsibilities to include medication reconciliation, vaccine administration, and other patient care activities under appropriate supervision. Long-term care encompasses a broad spectrum of health and social services designed to assist individuals who have lost functional capacity or never developed the ability to perform activities of daily living independently. This care continuum addresses both medical needs and psychosocial support requirements for individuals with chronic illnesses, disabilities, or age-related functional decline. Kane et al., 1998. The conceptual framework of long-term care extends beyond traditional medical models to encompass assistance with activities of daily living, ADLs, such as bathing, dressing, eating, and toileting, as well as instrumental activities of daily living, IADLs, including shopping, cooking, managing finances, and transportation. This comprehensive approach recognizes that functional independence requires support across multiple domains of daily life. Long-term care services are delivered across diverse settings, including nursing homes, assisted living facilities, adult day programs, and home-based services. This continuum allows individuals to receive appropriate levels of support while maintaining the highest possible degree of independence and quality of life. The choice of setting typically depends on the individual's functional status, medical complexity, family support systems, and personal preferences. The need for long-term care services is projected to increase dramatically as the population ages, with the number of Americans aged 65 and older expected to double by 2050. This demographic shift will place unprecedented demands on long-term care infrastructure and financing systems, requiring innovative approaches to service delivery and workforce development. Colello, 2013. Eligibility for long-term care services is typically determined by functional assessment rather than specific diagnoses, focusing on an individual's ability to perform essential daily activities safely and independently. Older adults represent the largest population requiring long-term care services, as advancing age is associated with increased prevalence of chronic diseases, cognitive impairment, and functional limitations. Individuals with chronic diseases such as Alzheimer's disease, Parkinson's disease, and end-stage renal disease often require long-term care services as their conditions progress and functional abilities decline. Alzheimer's disease in particular represents a growing challenge for long-term care systems, as individuals with this condition may require specialized memory care services and eventually progress to needing assistance with all activities of daily living. Patients with rehabilitative needs following acute medical events such as stroke, hip fracture, or amputation may require temporary long-term care services while recovering functional abilities. These individuals often benefit from intensive rehabilitation programs that can help them regain independence and return to community living, highlighting the important role of long-term care in supporting recovery and functional restoration. Terminal care represents another important component of long-term care services, with hospice and palliative care programs providing comfort-focused treatment for individuals with limited life expectancy. These services emphasize pain management, symptom control, and psychosocial support for both patients and families during end-of-life transitions, typically serving individuals with prognoses of 6 months or less. Pharmacy services in long-term care settings encompass both distributive and clinical functions, adapted to address the unique needs of residents with complex medication regimens and multiple comorbidities. Specialized packaging systems, including unit dose and multi-dose packaging with date and time labeling, help ensure accurate medication administration in environments where nursing staff may be responsible for managing medications for dozens of residents. Consultant pharmacy services represent a critical component of long-term care, with pharmacists conducting regular medication regimen reviews to identify potential drug interactions, inappropriate medications, and opportunities for therapy optimization. These reviews are mandated by federal regulations and have been shown to reduce medication-related problems and improve clinical outcomes in nursing home populations. The role of consultant pharmacists extends beyond medication review to include policy development, staff education, and regulatory compliance support. These professionals help long-term care facilities develop and maintain medication management protocols, train nursing staff on safe medication practices, and ensure compliance with federal and state regulations governing pharmaceutical services in institutional settings. Prescription abbreviations, commonly referred to as SIG codes, represent a standardized system of communication that enables efficient and accurate prescription writing and interpretation. These abbreviations facilitate clear communication between prescribers and pharmacists while reducing the time required to write and process prescriptions. However, the use of abbreviations also introduces potential for errors when abbreviations are misinterpreted or confused with similar appearing codes. Common frequency abbreviations such as QD daily, BID twice daily, TID 3 times daily, and QID 4 times daily provide standardized ways to communicate dosing schedules. Route-specific abbreviations, including PO by mouth, IV, intravenous, IM, intramuscular, and SL sublingual, clearly specify administration methods, while anatomical abbreviations like OD, right eye, OS, left eye, and AU, both ears, indicate specific body locations for topical medications. The Institute for Safe Medication Practices and other safety organizations have identified certain abbreviations as error-prone and recommended against their use in clinical practice. For example, QD can be confused with QID, leading to fourfold dosing errors, while U for units can be mistaken for zeros, potentially resulting in tenfold overdoses. Modern electronic prescribing systems increasingly incorporate decision support tools to reduce these risks while maintaining communication efficiency. ISMP 2015. The healthcare delivery system continues to evolve in response to demographic changes, technological advances, and policy reforms aimed at improving quality while controlling costs. The growing emphasis on value-based care, population health management, and care coordination will likely drive further integration between acute care hospitals, long-term care facilities, and community-based services. Pharmacists in all settings will play increasingly important roles in medication therapy management, chronic disease management, and care transitions, requiring expanded clinical skills and interprofessional collaboration capabilities. The success of future healthcare delivery models will depend on the ability of institutions and professionals to adapt to changing payment structures, patient expectations, and quality requirements while maintaining focus on improving health outcomes for diverse populations.